Hello and welcome. In this video, we will be discussing diseases of the small bowel. A good way to organize diseases of the GI tract is to take each segment, such as mouth, esophagus, stomach, and for each name the most important congenital abnormality, acute inflammatory disease including infections, degenerative autoimmune diseases, and neoplasias. For the small bowel, there are two important congenital diseases. The first is duodenal atresia. Atresia is a process in which there's failure of the formation of a segment of the tract. It can occur anywhere down the GI tract, but commonest is in the duodenum, about 50%. The important association of duodenal atresia is that 30% are associated with trisomy 21. Another 10% are associated with other underlying diseases. So it typically does not occur in isolation. Here's an image that shows a good illustration of what the atresia looks like, in which we have a normal first and second portion of duodenum with the ampulla about there, and then distal to that we can see a narrow segment, and this can be any degree of narrowing up to complete failure of a lumen to form. As most of the air in the GI tract comes from swallowed air, the abdominal X-ray has a very characteristic feature in which we see air forming in the stomach, which can pass through the pylorus and form in the proximal duodenal segment. And on abdominal X-ray, that shows up as stomach and proximal duodenum, and so that is called the double bubble. Because of the obstruction, patients present with vomiting in the first or second day. This is a useful diagram for thinking about all of the causes of vomiting in the newborn. And there are three that are common enough to lump together. We are discussing here duodenal atresia, but this is going to have the same mechanical effects as an annular pancreas, which constricts roughly the same area. This obstruction is going to present with symptoms 1 to 2 days after delivery. Patients will have vomiting, a pure reflex of reverse peristalsis coordinated with dilation of the lower esophageal sphincter. And because the common bile duct is included in the fluid regurgitated, the color will be green because it is bilious. By comparison, pyloric stenosis affects the region of the pylorus. This typically presents around 4 weeks postpartum. It has very forceful vomiting, referred to as projectile vomiting, but because the obstruction is proximal to the ampulla, it is gray in color or non-bilious. TE fistula has a blind-ended proximal tube with the distal tube going into the trachea. This then presents on the first feed when the milk goes into that blind-ended tube and immediately comes out again. So the time is the first feed, and this is not vomiting, this is more regurgitation, a passive bubbling up of fluid, mostly from the esophagus. And the color will be that of milk, which is what the patient is trying to swallow. The second important congenital disease of the small bowel is Meckel's diverticulum, and this is an embryologic remnant. Embryology is a long and difficult subject and generally non-rewarding, but one thing that is worth knowing about is to be able to draw week 4, because this is when we start organogenesis, and this is what it looks like. And there's the eye right there. These are the structures that one can name from this. This is the yolk sac, and it has a named channel connecting it called the vitelline duct. And it's from the yolk sac that the first primitive gut tube is formed. From this will grow the mesonephros, the aortic tube, which will join to the heart, and the notochord along the dorsal aspect. A number of important diseases can be seen here. A failure of the vitelline duct, also called the omphalomesenteric duct, is what gives rise to Meckel's diverticulum. When the allantois fails to involute, the patient develops a urachus. Failures of the branchial clefts can not only leave cysts in the neck, but also critical diseases in the 22q11ds syndrome. Formation of the cloaca will occur here with the division of the genitourinary and GI tract and developmental abnormalities of the kidney and bladder out of the mesonephros. So week 4 is well worth learning. Failure of the involution of the omphallomesenteric, also known as the vitelline duct, forms Meckel's diverticulum. It can best be thought of as the rule of twos. It's present in 2% of the population. It's usually about 2 inches long. It's found 2 feet from the ileocecal valve, and it has about 2% chances of being symptomatic, and that's before age 2. So the commonest presentation is an incidental finding at surgery. Of those that are symptomatic, they can present with abdominal pain, and this can be associated with bleeding because 50% of Meckel's diverticulum will have ectopic gastric mucosa, and this can develop peptic ulcer disease. The treatment obviously is one of surgery. Just a word on vocabulary. Heterotopia and ectopia are synonyms, and they are normal tissue in the wrong location. A hamartoma is normal cells with an abnormal architecture. Adenomas are benign neoplasms of glandular tissue. Meckel's diverticuli are true diverticular, meaning it is all the layers of the bowel wall. Pseudodiverticuli do not have all the layers, and usually it's just the mucosa, and this is most commonly seen in diverticulosis of the sigmoid colon. Acute gastroenteritis is usually due to a viral infection in children. These have a characteristic epidemiology in which they're commonest in the spring and fall. The 3 commonest families that are involved are the rotavirus. This used to be the most common cause until 2006 when a vaccination was developed. And so now it's a disease one's only really going to see in absent vaccination, so that would include in undeveloped nations. It's a disease of the very young and typically seen before 2 years of age. We're now starting to see that the most common virus is norovirus. This is commonly associated with outbreaks from a single source, so this is where we see cruise ships and other things like that. And it affects all ages. It's a highly contagious virus. And then the third commonest are the enteric adenoviruses. And these are most commonly seen in children before age 4, and they're commoner in the summer. Acute viral gastroenteritis has 2 common presentations. The first is diarrhea. This is defined as 3 or more loose stools per day. It is an acute diarrhea, which means that it occurs in less than 2 weeks. And it is non-bloody, being viral in type, which means that there are no neutrophils if one looks in the watery fluid that's passed. The more problematic presentation is that of pain. This tends to be a colicky pain, which means that it waxes and wanes, raising the question of whether it's an obstruction. The differential diagnosis of this abdominal pain is that of the diffuse abdominal pains. So in addition to viral gastroenteritis, the differential includes small bowel obstruction, small bowel infarction, ruptured abdominal aortic aneurysm, obviously not seen in children, and early appendicitis. The diagnosis really is clinical, And the key in recognizing the viral origin is not just that it's part of an epidemic seen in other children in the community, but if you can see involvement of multiple organ systems. So if the child has upper respiratory symptoms or lower respiratory symptoms, but the single best one is if you can show a viral type rash. These tend to be benign, self-limited, so the concern for treatment is merely to monitor for dehydration. Small bowel obstruction centers on the word obstruction, which in the broadest sense is any impaired flow of the luminal contents. In common usage, obstruction is usually reserved for mechanical pathology. Failure of flow due to functional causes is usually referred to as ileus. One can see in this table the commonest causes of small bowel obstruction. The most common cause in the United States is adhesions, but in the third world, where there's much less access to medicine, it's going to be incarceration of hernias. Two other diseases worth noting are volvulus and intussusception, and we'll discuss them below. Adhesions refer to fibrous bands between loops of bowel and the abdominal wall. These most commonly occur after previous abdominal surgery. The problem with these fibrous bands is that they allow for kinking of loops of bowel as they get contracted in the scarring, and also that they form internal hernias that can trap and bind loops of bowel. Most of the time this is a subacute or partial obstruction and can be monitored by fluid restriction and time, but if it is complete, one often has to do surgery, which is a problem because that's going to form scars of its own. Hernias refer to the protrusion of bowel through a part of the abdominal wall. And three terms are worth noting when we discuss hernias. A reducible hernia is one in which the bowel can be returned to the abdomen. When a bowel is fixed or trapped in the space, it is called incarcerated. And when it starts to impair the blood supply, it is called strangulated. The key idea behind hernias is that this point of narrowing can start with only a small amount of pressure. But if that pressure is enough to give us occlusion of the venous system, a low-pressure system itself, then that can start to build up engorgement of blood in the trapped bowel. And when one takes that venous occlusion and adds the volume of congestion, the pressure can build up enough to give arterial occlusion. And this then cuts off the blood supply, and that leads to infarction. So with an incarcerated hernia, the concern is not that it's a infarcted bowel immediately, but that some event will start venous congestion that will then lead to an occlusion with enough force to exceed the arterial blood pressure at the root of the hernia. Intussusception refers to a telescoping of one segment of the bowel into another. The commonest place to see it is in children, in which the terminal ileum intussuscepts into the ascending colon. And one can see here, this would be where the terminal ileum would come, and once you get caught into the peristaltic waves of the other colon, you can literally continue to milk the bowel up. Just as we saw with the herniation, that then is going to compromise the blood flow at the point of entry, which will go through its venous compression, increasing pressure to arterial compression and infarction. It doesn't have to just be in the terminal ileum. Anything that gives you a leading edge that can catch peristalsis. The presentation in children is of a small bowel obstruction. But on physical exam, one can sometimes feel that it is empty in the right lower quadrant, but there is a sensation of a mass higher up where there's double bowel. Because of the risk of infarction, the bowel has to be reduced, and that can be either by using radiologic fluids or by surgery. Volvulus refers to the twisting of bowel on its mesentery. And this occurs if the mesentery has a reasonably broad attachment to the bowel with a rather narrow attachment to the body wall, because that narrowness allows for that rotation. In adults, the commonest place to see this is in the sigmoid, but in children, it's more common to see it in the cecum. Surgical correction and removal of necrotic bowel is necessary. Small bowel presents with abdominal pain, and this is a diffuse abdominal pain. The pain is colicky, which means that it waxes and it wanes. And this is something to see with an obstruction of any tube. 3 disease associations of colic are kidney stones in the ureter, gallstones in the gallbladder, and small bowel obstruction. So colic is rather a magic word. We've already noted the differential diagnosis of diffuse abdominal pain. It includes viral gastroenteritis, small bowel obstruction, small bowel infarction, ruptured abdominal aortic aneurysm, and early appendicitis. On physical exam, there is often tympany on percussion. The trapped gases create a rather drum-like structure, and so one gets hyperresonance by tapping on the abdominal wall. The other important finding is that there are sounds on auscultation. These are often described as tinkling bowel sounds. And this is important because in small bowel infarctions, there's usually no sounds at all. The key diagnostic test for small bowel obstruction is abdominal X-ray. And in this one can see air fluid levels. These can be recognized by the gravity flatness of the interface of the air and the liquid with the air trapped above it. And in any abdominal X-ray in which there are 5 or more air fluid levels, that is diagnostic of a small bowel obstruction. Just as a small teaching moment on abdominal X-rays, they tend to be a very insensitive and nonspecific test, but their uses are usually described as masses, gases, bones, and stones. After that, you pretty much have to go to CT scanning. Small bowel obstruction is a medical emergency. We can see there are a number of different causes, so there's no single treatment for it, but about 25% will end up going to surgery. And the major risk is proportionate to necrotic bowel. This can never be left in the patient. It's not salvageable. It has to be resected. Intestinal ischemia is a rather broad term which people mostly use for acute small bowel infarction. But in fact, there's a broader idea. Ischemia refers to anything that causes a decrease in blood flow. But this can be either arterial or venous. And if it is in the small bowel, this is due to thrombosis in the mesenteric vein. And this is found in hypercoagulable states. And that's a subject for another day. The other is to describe which part of the intestine that we mean. In general, the term mesenteric ischemia refers to blood supply of the small bowel. Colonic ischemia refers to the large bowel. Acute small bowel infarction comes from one of 2 basic pathophysiologies. The most common is thromboembolic. Embolism classically comes from the heart and is responsible for 50% of acute small bowel infarction. In other words, it's the commonest cause. Thrombosis is usually due to plaque in the superior mesenteric artery, and this is found in about 25% of cases. By comparison, chronic is not something that happens over hours, but happens over more than weeks to months, and it's almost invariably due to a progressive occlusion. The 2 commonest causes for this are going to be atherosclerosis and vasculitis. such as polyarteritis nodosa. And when the occlusion is greater than 70%, this is going to give a demand ischemia of abdominal pain 1 hour or so after eating. The second commonest cause of acute small bowel infarction is due to global hypotension, meaning there's a decrease in systemic blood pressure. This then causes ischemia in watershed areas. And there are two prominent watersheds of the gut. The best known is the splenic flexure at the junction of the superior mesenteric artery with the inferior mesenteric artery. And the second, less well known, is the rectosigmoid junction between the superior and the inferior rectal arteries. In this video, we're going to discuss the presentation of acute small bowel infarction. And the symptoms start as a sudden onset of abdominal pain. And the reason for that relates to the commonest cause, which is embolic disease of the heart. If we draw ourselves a heart with the aorta, then one can imagine the diseases in which there is a formation of mural thrombus. In the atria, one would see this in atrial fibrillation. And in the ventricle, one would see this in causes of ischemia that cause loss of motion of the heart, for example, myocardial infarction. And when these dislodge, they tend to go to two common sites: up the carotid, where they will cause an ischemic stroke, or they can go down the aorta, where there is the celiac, SMA, and inferior mesenteric artery, and most common is the superior mesenteric artery, where they cause small bowel infarction. So that sudden ischemia explains the sudden onset of abdominal pain. Eventually the necrotic mucosa will slough and bleed, but the bleeding typically isn't seen until the next day. Physical exam is negative. There's no peritonitis, so it's a soft abdomen. Perhaps the only sound that one can identify is a negative finding: there are no bowel sounds. And note how that compares to the tinkling sounds and the tympany of small bowel obstruction. Testing is by a CT angiogram to be able to visualize the superior mesenteric artery. This obviously is not an easy test to order, therefore there has to be a high degree of clinical suspicion. The natural history is very serious. If there is bowel infarction, that is inevitably fatal. And so the clinical evaluation has to be one of aggressiveness to resect anything that's dead, which can often only be determined by exploratory laparotomy. But normal bowel function must be restored. Celiac sprue is the most important autoimmune disease of the small bowel. It is a type 4 hypersensitivity, which means that it is cell-mediated, in which the enterocytes are killed by cytotoxic lymphocytes. As with all type 4 hypersensitivities, there is a genetic link, and it is HLA-D, HLA-DQ2, and DQ8 are always found, and their absence actually rules out the possibility of sprue. The pathophysiology is thought to work this way. Gluten is an important protein of grains, oats, wheat, and the water-soluble component of gluten is gliadin. And it is felt that in the enterocyte, tissue transglutaminase deaminides the gliadin to form an antigen-like substance that sensitizes the T cells, and that then triggers the autoimmunity. This has a very specific pathology. If we look at the normal small bowel, mild disease shows the infiltration of the lymphocytes into the small bowel mucosa, and one can make a diagnosis histologically by showing that there are increased numbers of lymphocytes in the enterocytes of this surface epithelium. So early disease can be diagnosed by performing a small bowel biopsy and counting lymphocytes in the epithelium. But with ongoing late disease, the bowel loses its villus architecture and ends up looking like this, with numerous cytotoxic lymphocytes infiltrating all through the mucosa itself. This is a loss of villus architecture, and that's seen in severe disease. Sprue has a bimodal epidemiology. It occurs in the first year of life, which will be a failure to thrive, and then, much like other autoimmune diseases, in the 20 to 30-year-old females who present with the symptoms of malabsorption. Malabsorption has a number of different presentations. There is a general presentation in which there's a failure of absorption that leads to steatorrhea, greasy, foul-smelling stools, and a general loss of weight, even with a normal appetite. But there are specific deficiencies as well. One can fail to absorb only the fat-soluble vitamins A, D, E, and K. And the commonest of these to present clinically is K, which presents with a bleeding diathesis due to factor deficiency. So they tend to bleed into joints and deep soft tissue. As well, there's failure of the mucosa in the duodenum. And the duodenum has 3 specific absorption analytes. These are iron, calcium, and folate. Iron will lead to iron deficiency, anemia, and fatigue. Calcium will lead to osteoporosis, and folate can also lead to the fatigue of an anemia. The physical exam is non-contributory. Testing really has 2 approaches. The easiest screening test is a serum anti-tissue transglutaminase antibodies. The gold standard is small bowel biopsy. In mild disease, this shows lymphocytic infiltration of the surface epithelium, and in severe disease, it shows loss of villus architecture. There are 2 main complications associated with celiac sprue. It is associated with an IgA blistering disease, dermatitis herpetiformis, that typically shows small group vesicles over the elbows and knees, and in association with the large increase in lymphocytes, there is an increase in GI lymphomas. The malabsorption is problematic enough that sprue should always be treated, and this is by putting the patient on a gluten-restricted diet. The most important unique neoplasm of the small bowel is carcinoid tumors, and nomenclature now is trying to shift to calling them neuroendocrine neoplasm. The definition of a neuroendocrine neoplasm is a characteristic cell on H&E microscopy with the production of vasoactive amines. And there are a large number of these, but the one most of us key on is chromogranin. One can look for this in the neoplastic cells and measure it in the serum. Carcinoid tumors are mostly found in the lung and the GI tract, and they have a highly variable presentation. In the GI tract, the most common site to find them is in the appendix, and they're often an incidental finding, and they usually have a very indolent course. The most aggressive tumors of the GI tract are found in the distal small bowel. Carcinoids in the GI tract tend to have 2 presentations. The local presentation is one of chronic obstruction, but the most memorable is the paraneoplastic syndrome of carcinoid syndrome. 10% of carcinoid tumors secrete clinically significant amounts of serotonin, and this has three characteristic symptoms: flushing of the skin, particularly of the upper body, diarrhea, this is a secretory diarrhea, and bronchospasm. Flushing and diarrhea are seen in 80 to 90% of cases, and bronchospasm is much less common at 10 to 20%. Note that the carcinoid syndrome does not present until it is metastatic to the liver. When it is present in the small bowel and produces the serotonin, this travels through the portal vein and all gets metabolized in the liver. So it's not until there are metastases in the liver that the serotonin can be sent straight into the hepatic vein and up to the right side of the heart in the inferior vena cava. Diagnosis is made by imaging for the mass with biopsy to prove the tumor, and the carcinoid syndrome can be identified by looking for 5'-hydroxyindoleacetic acid, which is the most important metabolite of serotonin. That brings us to the end of this video. Thank you for your attention, and we look forward to seeing you the next in the GI tract, diseases of the colon.